All right, so now that you've done chapter 12, all about health and stress, we're going to finish up section 3 with chapter 13 and chapter 14. So chapter 13 and 14 obviously go hand in hand. Chapter 13 is all about mental health disorders, while chapter 14 is all about mental health therapies, so used to treat these disorders. So for this video, we're actually just going to go over sections 1 through 3. So let's hit on what we're going to go over. We're going to discuss what normal behavior is and is not. So what is normal and what is abnormal? We're going to discuss the DSM model, so used to classify abnormal behavior and the mental disorders. And then we're going to hit on our first section discussing specific mental health disorders. We're going to talk about anxiety disorder, panic disorder, obsessive compulsive disorder, and trauma-related disorders, specifically post-traumatic stress disorder, or PTSD. For the next video, we'll get into the more severe mental disorders as they're classified. So give you a brief overview of what you're going to be able to do by the end of this video, be able to define a mental health disorder, apply the criteria used to classify and determine abnormal behavior, be able to identify the structure of the DSM model, and understands the strengths of using it and its weaknesses, and then be able to describe the components of excessive anxiety and distinguish the symptoms of anxiety disorder, obsessive compulsive disorder, and trauma-related disorder. And then we'll discuss a little bit of research on the biopsychological factors of the disorders. So what I want you to do is take a moment and think about what you think normal behavior is and what abnormal behavior is. Just take like a minute or so. You don't write it down if you would like, but just have it in your head at the very least. All right. So what I'm going to do is ask you a couple of questions that I want you to think about. And we're going to kind of go through each of these for this first section. So for your definition between normal and abnormal, are there some common elements between the two definitions? Does your definition of each of those account for cross-cultural differences between normal and abnormal behavior? If it doesn't, which it's okay if it doesn't, what else do you think you might need to incorporate into those definitions? Does it account for the distress that the behavior causes to themselves or others? If not, what else do you think in incorporating the distress it causes to them or others? What else might you need to incorporate? Is there an ideal way of behaving? With your normal behavior definition, do you set this ideal that has to be met to be classified as normal behavior? And then for the abnormal behavior, how do you account for the difference between abnormal behavior and just odd behavior? So think about that and have that kind of in your head, and I'll go through your definition that your book has. So a mental health disorder is a dysfunction in cognition, emotions, and social behaviors. That, and this is the key point, so I'm going to put this in red and highlight it, that impairs functioning or is not culturally expected. So that first question I asked, does it account for cultural differences? There are some cultures that have behaviors or show behaviors that we do not. And we show certain behaviors that other cultures would not. The idea of emerging adulthood, which we discussed in chapter 9, in some cultures would be considered odd because they think that you reach a certain age, you're automatically an adult. So that's one thing to keep in mind with the mental health disorder, is that it causes dysfunction, but it also has to impair their functioning within society, meaning school, things such as that. And it's not culturally expected, meaning these aren't behaviors that you see within the culture. So let's look at the 3 criteria used by psychologists and psychiatrists. So it's not culturally expected. So less, if you engage in the behavior less or more frequently. For example, someone with an eating disorder may eat more or less than someone on average. So they exhibit the behavior eating less or more than people within their culture. And social norms vary across culture. So comparing, say, America to Brazil, but they also vary across times. Behaviors that we have now, like that emerging adulthood, so the fact that, you're not considered an adult at the age of 18 would be considered odd in the 30s and 40s. So social norms vary across culture and vary across times. Something to keep in mind. If the behavior causes distress to the individual or those around them. So if somebody is suffering from anxiety or obsessive compulsive disorder, they have to obsessively check things. They're like making sure that your stove is off 20 times before you can leave the house. That would obviously cause distress to them, but it would also cause distress to those around them as well. And then finally, dysfunction. So it interferes with their ability to function. So that might be like, does the behavior impair their ability to hold a job, go to school, or have close relationships with others? So just put a note here for you to remember. These are the 3 criteria used in classifying abnormal behaviors. And also, so I'm actually going to just put it like this, mental disorders. So bear that in mind. So the 3 things you need to know in distinguishing abnormal and normal behavior is, is it not typical or culturally expected? Does it cause distress? And does it cause dysfunction? So let's look at a couple numbers now. So using old data from about 6 years ago, but there we are. And obviously, all these are very conservative estimates because people who have difficulty function may not go to mental health services, or unfortunately, they may not have access to mental health services. So that's something to bear in mind, that these are conservative. These are probably on the low end, numbers wise. So 18% of all Americans in 2014 or 18 or older were thought to be suffering from a mental disorder. So 18% of all Americans, 18 or older. But over one's lifetime, so as one lives their entire life, more than half of US adults, it's like 53%, I think exactly, will meet the criteria for a mental health disorder. Meaning, going back, and I'll go right back, they hit these three markers, it's not typical behavior or culturally expected. They have distress and they have some sort of dysfunction. That's not saying that they will be diagnosed with a disorder, but more than half will show the signs of suffering from a mental disorder sometime in their life. That's conservative estimate. There's little gender difference over lifetime risk. So between males and females, it's about half for both. But adult female males were more than likely to be diagnosed with any mental disorder or a serious health disorder. That's because on average, women go to the doctor more than men. So that would make sense. Though the average is about the same, that half of males and half of females, all over their time of their lives, would be diagnosed with the disorder. Or have the markers for a mental disorder. Only about oh no, I'm trying to say women will just be diagnosed with it more due to the fact they just go to the doctor more. Among teens specifically, so 13 to 18, 22% are 22% were likely to experience a mental disorder sometime in their life, and ending suicide is actually the 10th leading cause of death in the U.S. So I share those numbers with you to understand that in discussing mental health disorders, it's to kind of take the stigma away in a way, because over half, so 1 in 2 people will have the markers of a mental disorder sometime in their life. Just when you're reading through this, be very understanding that, you know, it's easier to do this in class. Be very understanding that somebody you know, or you may yourself be suffering from something like this. So let's go into the theories to explain abnormal behavior. So first and foremost, psychopathology is actually the study of mental health disorders. So it's just an offshoot of psychology. So psychiatrists and psychologists, they study, if they are working with people with mental health disorders, they have a background in psychopathology. And there are 3 main approaches for understanding abnormal behaviors: the biological approach, the psychological approach or theory, and the socio-cultural approach or social cultural approach. These are going to sound very familiar to you because this goes all the way back to chapter 1 with those theories and perspectives. So if you had a good handle on that, it'll make it easier to understand these 3 theories, because that's where they fall into. So let's look at the medical model first. So the biological theories or medical model means that the behavior, the abnormal behavior, is from a physical cause. So give you a couple examples right here. So it could be due to genetics. It could be due to a hormonal imbalance or to a brain dysfunction. Someone who attributes, there we go. So right there. So someone who works within and takes a biological or medical model approach to understanding abnormal behavior, they may say depression is due to a hormonal imbalance. So they almost view it as like a broken leg. That if it's due to a physical process, the way you would treat it is by surgery or medication, like a broken leg. You break your leg, you treat it by, getting it in a cast. they view mental health disorders and abnormal behavior the same way. So treatments as this would be, like I said, medication, surgery. But don't worry too much about that right now, as we'll get more in depth into that in chapter 14. So moving on from there, we have the psychological theories. So there we go. So I'm actually going to put the definitions for that right here as we go through them. So the psychoanalytic, as you remember, that's good old Freud. So that's all about the fact that there is a conflict between the unconscious and the unconscious. So like the id and the outward demands of society. So as you recall, Freud's all about the unconscious, the sexual urges that one has. So according to Freud, mental disorders stem from their inability to resolve conflicts between their id, superego, and ego. And that leads to mental health disorders. Or their instinctual, sexual, and aggressive desires they have and the demands of society. So that's what Freud would say mental disorders are from. The social learning perspective. So this one's all about, is all about classical or operant, actually, there we go. Classical, operant, or modeling. So for example, so it's their responses to the stimuli and consequences of their behaviors lead to abnormal behavior. Or they might learn their abnormal behavior from others. With the cognitive perspective, that is so their thought processes cause the abnormal behavior. For example, you may have this little voice inside your head, or your conscience, if you want to call it as such. So the voice inside your head, does it encourage you to do well, or does it criticize you? Like when you screw up, does the voice inside your head say, oh, well, try harder next time, it's okay? Or does it say, no, you're stupid, you fail miserably, you just suck at this? So that's as you recall, cognitive is all about thought processes. So the thought processes lead to the abnormal behavior. And then humanistic, that's the one all about self-fulfillment. So that one is going to be the fact that they lose touch with personal values, and that causes them to, actually, let me rephrase. Or they lose their sense of self. So they can't fulfill their basic needs. If you recall from the hierarchy of needs, that would be, well, actually, think of it like this instead: basic, biological, and psychological needs. So they cannot attain self-actualization. There we are. So because they can't obtain self-actualization, which, as you recall, the humanistic perspective is the one that promotes like self-fulfillment, self-achievement, and reaching self-actualization. So because they cannot reach self-actualization, they experience this the personal distress, and that leads to the abnormal behavior. And don't worry if you're still slightly confused about these, because I'll give you examples with each of the disorders. And we actually will talk about this a little bit more in chapter 14 as well, because each one of these theories and perspectives has a therapy that goes along with it. So that might help you understand it a little more as well. And then finishing up, we have our sociocultural theories. So the sociocultural theories emphasize the fact that society and culture play a role in mental health. So that's saying like abnormal behavior has to be understood when looking at age, race, gender, social roles, SES, socioeconomic status, before we can actually understand abnormal behavior. So like social conditions like poverty, discrimination, environmental stressors have to be understood to understand the abnormal behavior. And then finally, the biopsychosocial model, which combines all of them. So it's all the perspectives in one. So, and this is usually the best way to take, because you kind of encompass everything. So I'll give an example. A person with depression. They have changes in their brain chemistry. That's a biological factor. It's usually diagnosed in women more. That's a sociocultural factor. And it's people who suffer from depression are likely to have negative patterns of thinking. That's a psychological factor. So, according to this model, we have to kind of include all these factors to understand and get a full view of what's abnormal, what behavior is abnormal or not. So let's go through a quick review of section 1. So Susan enjoys eating garbage when she is hungry. It's a pica specifically. By which criteria can Susan's behavior be considered abnormal? Well, it violates social norms. If you recall, norms are unwritten rules in society. Talked about them in chapter 10. If you see someone eating out of the garbage, you are going to be most likely to kind of question that and think it's odd because it breaks norms, breaks social norms. And then what is the likelihood that you or someone close to you will be diagnosed with a mental disorder sometime in your life? That'd be about 50% lifetime prevalence. And then, let's see, finishing up, Dr. Kwan believes that Ken's abnormal behavior has resulted from a distorted sense of self and a loss of personal values. So it's all about the self. So let's put that in red. Loss of personal values. Okay, well, which one is all about sense of self? That'd be the humanistic model. Right. So that's section 1. So we have a pretty good idea of what's abnormal, what's normal, what different views people take in looking at abnormal and normal behavior. So now we got to talk about what's used to diagnose it. Well, that is known as the DSM. And before you get worried that you have to know every single one of these, no, I don't expect that. We're not going to talk about all these anyway. You just need to know the ones that we talk about within our book. So this just shows you the categories that they exist. This is also to give you a good idea to work on your chapter 13 activity too. As these are listed, you can see these. See, we're going to talk about these. We're going to definitely talk about these. If I can get this thing to work. There we are. Let's see. We're only going to talk about these. I'm not going to talk about premenstrual disorder. See what else we got. Yes, all the anxiety disorders. And then we're going to hit on all these. See, and then finishing up. We don't really talk about any of these. I mentioned we actually have talked about these before. Talked about them in chapter 3. Talked about these in what did I say? Sorry, chapter 4. Not going to talk about the sexual dysfunctions, gender dysphoria, any of the impulse control. We talked a little bit about substance-related and addictive disorders, a little bit. We're not going to talk about the paraphilic disorders either. But we are going to talk about personality disorders. All right, so this is how the DSM is structured. So this is actually from the newest, the DSM-5, came out in 2013, and it's just catalogs, and it's got about 300 diagnosable mental disorders. And then it has the symptoms, and they're in 20 major categories. And then it also has conditions that have to be met for one to be suffering possibly from the mental disorder. One thing to keep in mind, and I will put it at the end of right here, get a text box, that you need to keep in mind when it comes to the DSM. The DSM is not a treatment guide. It just gives you an overview and an understanding. It doesn't really go into the cause of the disorders. It doesn't go into how to treat them. It's theoretical in nature, meaning there's no set theory behind it. It just offers you, okay, well, this is the disorder. These are the symptoms. This is what somebody may look like who's suffering from it. The treatment comes into play depending on what type of psychologist or therapist you are. So that's something to bear in mind. So it's not a treatment guide. So how good is it as well? That's easy to answer and hard to answer because it's good to a point. So I'll explain what I mean by that. So we talked about reliability and validity in chapter 8 when we talked about intelligence testing. So reliability is the consistency of the measurement system. So whatever you're doing so you're using DSM to measure an anxiety disorder. You would expect 2 different therapists to give a similar judgment based on those same symptoms. So across the board, it has to be consistent. And then validity is, does it do what it's intended to do? So you should expect that the DSM model should be accurate in diagnosing people who are suffering from some sort of dysfunction. Should also be accurate in the label it applies. It shouldn't give a label of anxiety disorder when they might be suffering from schizophrenia. So people who are depressed should be diagnosed as depressed. People who have drug issues should be diagnosed with a substance-related or substance abuse disorder. But, so the DSM has been around for about 60 years or so. Numerous revisions have been made, so about 5. It's on its 5th one, about to probably be on its 6th soon. But one key thing to note is it's made few changes in diagnosing personality disorders. I will explain why that is when we talk about the personality disorders. And it doesn't guarantee an accurate diagnosis because of this idea of comorbidity. Someone can meet the criteria for more than one disorder and can in turn be diagnosed with both. So people who have anxiety disorder are more likely to also suffer from depression, the comorbid. So and there are certain biases that exist. If a doctor is an expert in anxiety disorders, they might be more likely to diagnose someone with an anxiety disorder due to their personal bias they have. And so that's something to keep in mind too. So that is the DSM. Not really a lot on it, just know like the problems that it has with it. It's kind of questionable, but it's the best we got. It's what we got to work with. So let's go through and review section 2. So the purpose of the DSM is to explain the causes of mental disorders, describe the symptoms of mental disorders, indicate the frequency of mental disorders, prescribe the treatment. So as I said before, it's atheoretical, meaning it doesn't offer any theories behind why they're suffering it. So it doesn't explain the causes. It indicates the frequency. Nope, doesn't do that. Prescribe treatments. Nope, doesn't do that either. It just gives you the symptoms of it. And then the DSM model emphasizes which aspect definition of abnormality. Inability to function. That's something to keep in mind as well too. And make sure you're reading your book. That's why I kept it in here, because you should be reading your book. And then which of the following is true? Which of the following is true about diagnosis? A diagnostic system is valid if 2 different clinicians give a similar judgment or a consistent rating. DSM has eliminated the problem of comorbidity. Diagnostic label may serve as a self-fulfilling prophecy, or the DSM guarantees a accurate diagnosis. Well, give you a moment to think about that one. It's something that is unfortunately true. It can serve as a self-fulfilling prophecy. When you label someone with a mental health disorder, you may find they may be more likely to show the symptoms and signs of that disorder. You can read more about it in your book. It gives a really good example, an explanation of why that might be seen. So to finish up our last section for this video, I'm going to discuss anxiety, obsessive compulsive disorder, and trauma-related disorders. So first, we got to discuss the components of excessive anxiety. So we all have anxiety. These are all symptoms, if you're reading through this, that you feel when you're anxious. So, and I'm going to stress this, for every single disorder that I discuss, because it is a key point that you need to know, is, oh, it didn't do it. There we go. Excessive anxiety is a problem when it affects their ability to function. When you're anxious about something, most people may find they can get through their day, no issue. People who suffer from excessive anxiety may not be able to hold a job. Some can't even leave their houses due to agoraphobia, which we'll talk about in a couple of slides. So there are 4 components to excessive anxiety. I put cognitive and emotional together, but I'll separate it as we discuss it. And let me highlight each of these. Oh, gracious. Yeah. So the 4 components of anxiety, as you can see, are physical, cognitive, emotional, behavioral. So let's go through each of these. So cognitive, physical, that one's pretty straightforward. These are the physical signs you show when suffering from anxiety. Dizziness, sweaty palms, elevated heart rate, dry mouth, sweaty palms. I said sweaty palms twice. Don't worry about it though. So if you find out that you have to do a public presentation and you don't really like doing those in public, like presenting in front of others, you may feel all these components. But someone who suffers from excessive anxiety may feel that dizziness, elevated heart rate, sweaty palms, and dry mouth all the time, no matter what the cause. Just laying in bed may cause them to feel that. Cognitive, so people with excessive anxiety have concerns that are out of proportion and unrealistic to the actual amount of harm that could occur. So someone with excessive anxiety may get, when they find out they have to drive somewhere they've never been, they may think, oh, well, they blow it out of proportion. So they think, well, I'm probably going to get lost. I'm not going to find my way there. I'm going to be late. I might get into a car accident. They ruminate on these. So they worry a lot. They fear that they'll lose control of a situation. And then they exaggerate the danger of the situation. And that's kind of tied to paranoia. Then third, emotional reactions. So that's just the feelings that you feel. So terror, dread, panic. And then behavioral, that's, I'll put this right here. There we go. Behaviors. That might be like escaping, fleeing the situation, or freezing, meaning that they unable to move, unable to do anything. And I'll explain a little further in depth when we talk about the types of disorders. And obviously, these 4 components of excessive anxiety altogether is going to disrupt the person's quality of life, and is going to cause them a lot of distress in their life as well. So let's look at a couple of these disorders. So the anxiety disorders, as classified by our good old DSM, are generalized anxiety disorder, or GAD, phobias, and panic disorders. So generalized anxiety disorder is kind of a catch-all. So it's free-floating anxiety, meaning it's anxiety that's not really tied to a specific trigger or thing. If you're afraid of snakes, or actually, let's keep using the public speaking because I seem to really like that example. If you are get really anxious about public speaking, you're only going to feel anxious when that trigger is there. So when you have to public speak, someone with generalized anxiety disorder feels that exact same amount of anxiousness and dread about anything, and nothing, because it's not really tied to anything. So somebody, they seem to worry about it, but they can't place their finger on why they're upset or concerned. So they worry about what car they should have, what house they should buy, their children's health, how well they're doing at their job. Reasonable things to worry about, but also being late, wearing the right outfit, what they ruminate and constantly are anxious about what they should make for dinner. Things that should not cause you distress and dysfunction usually. And about 2 to 3% of American adults will experience generalized anxiety disorder in any given year, while 14% of American adults meet the criteria for the disorder sometime in their life. Bearing in mind, that's not that they get diagnosed with it, they just have the symptoms of it. So that's generalized anxiety disorder. So what about panic disorder? Panic disorder is marked by overwhelming attacks known as panic attacks. They're like dread and worry that are accompanied by physical symptoms. And what's kind of frightening about these panic attacks is they mirror the symptoms of a heart attack. So they unfortunately become a vicious cycle because one is constantly worried about having a panic attack, which in turn can trigger them having an attack. So, yeah, about 1 in 5% of American adults will develop a panic disorder sometime in their lives. And it's actually 2 to 4 times more common in women compared to men. And then phobias. Phobias you've probably heard of. So, throw that one right here. So these are intense and irrational fears that center around a specific trigger or phobia of something. So that might be a couple of them. Social anxiety disorders. Snakes, heights, spiders, so on and so forth. So they see the snake, that's their trigger, and it causes them to have a fear and get anxious and have symptoms similar to the anxiety disorder and the panic disorder. So they then lead to a pathological or constant, we'll just go with constant, avoidance of the trigger. So if you're afraid of snakes, you're going to do everything. If you have a severe phobia of snakes, you're going to do everything you can to avoid snakes. Couple other ones, social anxiety disorder. So that's a phobia of social situations, and agoraphobia. So agoraphobia is tied to panic disorders. Not always, but it is usually. So agoraphobia is like fear of social situations, fear of leaving one's house. So agoraphobes may not leave their house on months on end. They avoid social situations, avoid leaving. And the reason that is, and why it's tied to panic disorders, is they usually suffer from panic disorders. So they want to do everything they can to avoid, and I'll put it right here. They want to do everything they can to avoid having a panic attack. So they do all these things so it doesn't cause them to have a panic attack. So eventually, they just stay inside for months on end. And I'll hit on it a little bit in chapter 14, how that's treated too. All right, so going on from there. So I go into phobias a little more right here. but I just provide you kind of a quick overview. So persistent fear and avoidance of the specific object because it causes severe anxiety, panic attacks, inability to function. It's also the most common disorder worldwide. I'm sure many of you probably suffer from some sort of phobia. Mine is heights. Not a fan. And then social anxiety disorder, that's a specific type of phobia. So it's also an anxiety disorder as well. And that's a fear of being evaluated negatively by others in a social situation. So one who suffers from this may always feel like someone's talking bad about them or everybody's looking at them, judging them. That's a marker of social anxiety disorder. Okay, and then moving on from there, let's talk about obsessive compulsive disorder. So, we all have weird, intrusive thoughts. You may have been driving your car one night and you think, what if I just jerk the wheel and just ran off the road? That is an intrusive thought. Those are relatively normal. Though that one's a severe case. But another intrusive thought may be when you're driving to school one day and you're like, did I leave the stove on? Did I cut my coffee pot off? Because you're starting to worry about maybe accidentally causing a house fire. So what do? Some of us might be compelled or feel the need to turn their car around and go and check. But when it becomes an issue and turns into obsessive compulsive disorder is when we feel this every time you get in the car. Every single time you get in the car, you have to go check the stove. You have to make sure you've cut the light off. You have to make sure that you turned your coffee pot off. That is a marker for obsessive compulsive disorders. So I'll explain the difference between obsessive and compulsions. But one key thing that'll help you keep these separated, obsessions are the thoughts. Compulsions are the behaviors. So obsessions are you constantly worrying about checking the stove. It's a thought that's recurrent, that constantly is intruding on your awareness. Let's say you're trying to take a test, but someone who suffers from obsessive compulsive disorder may constantly be thinking about it. Like no matter how hard they try, they're constantly thinking about it. While an obsession is a compulsion is a behavior that a person feels a strong urge to perform. So if your obsession is dirt or contamination, your compulsion may be to constantly wash your hands hundreds of times a day. We all may have an obsession and we all have a compulsion, but when it turns into obsessive compulsive anxiety disorder, hold on one. Sorry about that. Something seemed to be going on. So where was I? Oh, obsessive compulsive disorder. So it's a form of anxiety disorder where you have those intrusive thoughts, those obsessions, and then you're compelled to engage in repetitive actions. So the compulsions. So you have the obsession and the compulsion. And it interferes with your ability to function. So someone who suffers from obsessive compulsive disorder uh, has to wash their hands. They have to. They feel like if they don't, they will die. Something terrible will happen to them. These rituals actually provide them temporary relief. So let's think back to one of the psychological theories. So I have a intrusive or recurrent thought that I have to wash my hands. It makes me feel anxious. It makes me feel bad. So I have this ritual that I perform. So I add something into my environment by washing my hands. Okay. That removes those negative thoughts, gets rid of the negative thoughts. So I'll be more compelled to perform that behavior again. It's conditioning, is what I'm saying. It's operant conditioning. So the reason why they keep doing these rituals is because it does provide them relief, but only for a short period of time. So if they don't perform the rituals, their anxiety goes up. But if they do perform their rituals, they'll be appeased for a little bit of time. And there have been good and bad examples of this within TV. If you've ever seen Scrubs, there was a character who suffered from an obsessive compulsive disorder. It was a really good example of it too, actually. One bad example is this TV show from the 2000s, Monk, where it presented his obsessive compulsive disorder as like a superpower. Not quite how it works. And it's not always related to cleanliness either. So, and then one other type of anxiety disorder is hoarding disorder. If you've seen the TV show Hoarders, that's exactly what it is. It's also related to obsessive compulsive disorder. Their obsession is that if they throw something away, they might need it again. They need whatever it is, no matter how big or little. They have to have it. So their compulsion is to keep everything. So they it used to be a form of classified within the DSM as a obsessive compulsive disorder. Now, in recent times, they consider it its own disorder, but similar to obsessive compulsive disorder. So they can't discard possessions, so they have to keep everything. They live in sometimes awful living conditions, and it obviously these conditions cause them significant distress and impairment in functioning. There are some, and I won't spend a lot of time on this because frankly I find it to be depressing. There are people who suffer from hoarding disorder specifically related to animals. So they have 30, 40, 50, 60 animals in their house at one time. You can imagine how that turns out, obviously. So finishing up with one you've probably recognized or heard of at the very least is post-traumatic stress disorder. Post-traumatic stress disorder is a trauma-related disorder. So it's usually characterized or marked by distressing memories, some memories that they constantly are coming back to, feeling emotionally numb, hypervigilant, and that develops after the exposure to a specific event. So it could be the sudden, unexpected death of a loved one, witnessing a violent crime, a deadly traffic accident. Those can all cause post-traumatic stress disorder. So they avoid situations, thoughts, or memories associated with the trauma, but they sometimes experience these flashbacks to it. So you've probably seen the signs like I'm a PTSD war vet. Please don't shoot fireworks outside my house. That's because the sound of the fireworks can trigger a flashback to maybe that event when they saw someone get shot or got shot themselves, or traumatic events that happen in war. And in that flashback, they feel like they're actually back in there. They can't separate reality from a memory at that time. And they may also experience depression, anxiety, irritability, and outburst of anger due to the PTSD as well. Some physical symptoms could be headaches, dizziness, chest pain, which sound very similar to panic disorder behaviors as well, and feelings of intense guilt. And obviously, these symptoms, these flashbacks, these triggering, distressing memories, obviously will impede their ability to work or meet obligations from society. So, finishing up, let's talk about some research. So these just will apply what we discussed. Take that first chapter and apply to each of these groups of disorders. So biologically speaking, there is genetic predisposition to excessive anxiety, meaning someone whose mother or father suffer from anxiety, they may be more likely to suffer from excessive anxiety as well. Psychologically speaking, the conditioning process, mentioned that as well, so that the conditioned stimuli are then thought to generalize to neutral stimuli, resulting in a variety of cues that invoke panic symptoms. For example, someone whose panic may be related to public speaking can then generalize to other neutral stimuli, meaning that they suffer from panic attacks due to being in public or being around certain situations. They also may develop fears by observing and hearing others' negative experiences. If you could theoretically suffer from a phobia, something you never even been around, because of other people's negative experiences to that. A reinforcement, an OCD, mentioned that one earlier. So you engage in the behavior that provokes the anxiety, and it reduces the anxiety. And then finally, cognitively, thinking processes. People who have a external locus of control, meaning they view situations as uncontrollable, are more vulnerable to anxiety disorders. And then finally, finishing up, as apparently I go into puberty, it seems, socioculturally, cultures that experience a lot of social change and war obviously are going to suffer from more anxiety symptoms, specifically PTSD. But luckily, people with a really strong support system function better after following a traumatic event because they feel that they can share it with someone. They can have someone who understands that they can to help them through the situation. So this is on your slide too, but this just kind of provides an overview of each one. Strongly recommend reviewing it to help you out. So let's go through a quick review. So Mary Lou is anxious and nervous all the time. She constantly worries about her family, her job, her schoolwork. Which disorder describes Mary Lou's behavior? So she's constantly worried about all these types of things. So there's no specific thing that she is worried or concerned about. So that'd be generalized anxiety disorder. Learning theories suggest that obsessive compulsive disorder is the result of faulty cognition. No, that'd be cognitive. Low self-esteem. No, that'd be more humanistic. Unconscious impulsive. No, that'd be more psychodynamic or psychoanalytic. Reinforcement processes. Keep in mind, those learning theories, they are about classical conditioning, operant conditioning, and social learning or modeling. And then finishing up, Abdul was involved in a 4-car pileup on the interstate 8 months ago. Since then, he's been having nightmares and flashback episodes to the accident. He also has difficulty concentrating and has withdrawn from his family and friends. So he would be most likely diagnosed with panic. No, not quite. They don't mention panic attacks, social anxiety disorder. Well, he's withdrawn from his family and friends, but you wouldn't have nightmares and flashbacks episodes. Generalized anxiety disorder? No, not quite. Doesn't say he's worried about things. So, process of elimination, post-traumatic stress disorder. So that is sections 1 through 3. So for our next chapter, we're going to kind of go through the rest of the disorders, the more severe disorders. And by severe, I mean marked by severe disturbances, severe dysfunction. So, as always, feel free to reach out with any questions or concerns. Visit the virtual office hours if you have any questions. Email me. Don't hesitate, but have a good day.